Thank you so much to Milteni for organizing this symposium and giving me the opportunity to present today this data. What are we trying to solve with this new strategy of transplant? I think that overall, really, when we do a transplant for acute leukemia, there are three main challenges that we need to consider and that we are really trying to solve for as a community. First, the graft-versus-host disease, the most life-threatening immune-mediated complication that can be devastating for our patients. And surely αβ T-cell depletion has dramatically reduced the rates of both severe acute and chronic graft-versus-host disease, as we heard also just now, and definitely has solved the donor matching issue. But then we have two other major issues, which are infections still present despite the improvement in supportive therapy, and ultimately the relapse incidence. And I would say that really the problem of reducing disease recurrence is what the needle has moved less in the last decades, despite the improvement and the different platform that we utilize. So that's where really, when we look at survival rates, if we want to increase this number, that's where we have to focus on. And so the problems that we are trying to tackle with our own strategy is really how to increase this rate of survival that already improved significantly when we moved from the positive selection of CD34 to the negative selection of αβ T cells. So the rationale really that we have utilized to build the approach that I'm going to show you is to build upon the success of αβ T-cell depletion, which again incredibly reduced the rates of acute GvHD and chronic GvHD, but still didn't fully resolve the problem of the infection and the relapse. And ideally, we need to have a net back of T cells that we can fuse early on after the transplant that can provide graft-versus-leukemia without causing graft-versus-host disease. And so that's why we have designed a clinical trial in which we are infusing this head back of T-allo10 cells at 35 plus minus 7 days post αβ T-cell depleted transplant. And here our goal was to boost the immune reconstitution, and specifically the αβ T-cell immune reconstitution, which is delayed because we are eliminating the cells from the graft. And we determined that really as as our efficacy endpoint, we wanted to improve the frequency of patients who were achieving in early CD4 immune reconstitution post-transplant. Here I can explain you better what are the T-allo10 cells, which are non-naturally occurring T cells. This is a regulatory T cell based product, but unlike any other regulatory T cells currently available, is an alloantigen-specific product. It is manufactured by stimulating CD4 donor T cells in the presence of host dendritic cells and IL-10. And in this way, we are able to obtain a cocktail of T cells which has as a key ingredient regulatory type 1 cells, which are characterized by the co-expression of the CD19 B and LAG3. And during that stimulation with the dendritic cells of the patients and the IL-10 become alloantigen specific and therefore are able to reduce the risk of graft-versus-host disease. Overall, we have a frequency of TR1 cells in this cocktail which is reaching up to 15%, while the rest is it's combined of polyclonal effector cells that maintain their ability of responding towards third-party antigens, therefore viral infected cells and tumor cells. And we have some nice data that we have published a few years ago that show that these TR1 specific cells also have a specific anti-leukemia activity in vitro against myeloid cells. So here we have a product which on one side can promote immune reconstitution by clearing infections, but not really increasing the risk of graft-versus-host disease. And so it's this the rationale that we have used for designing this trial, which is pretty straightforward. The backbone of the transplant is the alpha-beta T-cell depletion, as we have previously published in a number of papers without any pharmacological immune suppression, with a conditioning regimen which is myeloablative and in mostly TBI-based for children greater than 3. And busulfan-based for younger children. Here, the trial is open for pediatric patients and young adults, so we have treated up to 30 years of age. The ATG is given between day -9 and day -7. And then we have tested a single infusion of the T allogeneic cells at 3 different escalating doses, 1 time to the 5th, 3 times to the 5th, and 2 times to the 6th per kg. And then we have done extensive correlative studies up to 1 year post-transplant. Our phase 1A endpoint was to determine the recommended phase 2 doses, while the phase 1B endpoint was really an efficacy endpoint. And so here we look at how many patients were able to reach the threshold of 50 CD4 per microliter by day 60, challenging the biomarker that has been published and demonstrated to be correlated with reduced non-relapse mortality, GvHD and relapse in the cord blood and T-cell depleted setting. Here in this slide, you can see the cohort of the patients that we have treated, 21 patients with an age that spans between 1.7 and 24 years. This is a very high-risk population. Most of the ALL that we transplanted in this trial were CR2 or greater. We had AML, mixed lymphocyte leukemia, and patients with high-risk myelodysplastic syndrome with monosomy 7. All the donors were haploidentical, and the graft was consistent with what we see with alpha-beta depletion, a megadose of stem cell and a very nice depletion of alpha-beta T cells, less than 50,000 per kg in most of the patients. We didn't observe any dose-limiting toxicity, so no patient had really DLT, and specifically our main DLT was the development of grade 3 to 4 acute GvHD that we didn't see in anybody. We had only 2 relapses in the trial so far. Both patients in the cohort 1, the cohort who was treated with the lowest dose. One of these patients was transplant naive, while the second one had already failed a prior transplant. 4 patients overall developed steroid-responsive acute graft-versus-host disease. It was grade 2, 2 cases in cohort 1 and 2 cases in cohort 3. And amongst 16 evaluable patients for efficacy endpoint, 12 achieved the threshold of 50 per CD4 per microliter, meaning that we increased the proportion of patients reaching that goal from 31% in our historical control, alpha-beta depleted cells only, to a 75% in this cohort. In terms of viral activations, the cumulative incidences are comparable between the trial patients, the T allogeneic recipients, and the historical controls. However, what we see is a reduction in terms of incidence for the CMV and the adenovirus, which is dose-dependent, because we have a lower frequency in cohort 3 with respect to cohort 2 and cohort 1. And most importantly, we had only 4 cases of grade 3 viral reactivation, which were all adenovirus, which were determined grade 3 because the stools were positive, but no other grade 3 for CMV or other viral activations. Looking at the clinical outcome, first, no patient died in the cohort in the overall trial. So we were able to have a 0% transplant-related mortality about 6 months and 1 year, which compare favorably with the 9% of non-relapse mortality in the 36 historical controls. And looking at the efficacy by dose cohort, cohort 1, which received the lowest T allogeneic dose, had a 40% leukemia-free survival and GvHD-free relapse-free survival, while the therapeutic doses cohorts, cohorts 2 and cohort 3, achieved 100% 2-year leukemia-free and GvHD-free relapse-free survival. This clear dose responses really establishes 3 times to the 5th per kg as the recommended phase 2 dose. Finally, we look how these data compare with what is the standard of care for our center, and so what we call the naked αβ T-cell depleted transplant. And when we compare therapeutic doses cohort to the historical controls from our institution, this is a group of control which is matched for diagnosis, conditioning regimen, ATG regimen, and of course, αβ platform. TLC recipients achieved 100% 2 years GvHD-free, relapse-free survival in comparison with 61% in control. This positions the Allo10 as a major advance for the pediatric αβ T-cell transplantation. And moving now to the correlative studies, first we look how the TR1, which we really consider the key ingredient of these T-Allo10 cells, is trackable in our patients after infusion, and we can see that the TR1 cells by flow cytometry were detected shortly after the infusion, peaking around 20% on day 7. Although we see a long-term persistence using a clonotype tracking, which I'll show you in a second. Overall, across all T-Allo10 cohorts, the kinetics of TR1 cells differ significantly from controls, and in fact, a mixed effect longitudinal analysis show that the frequency of TR1 cells is significantly higher in the T-Allo10 patients in comparison with the controls. And we also see that, again, there is a dose-dependent effect with the recipients of the highest dose having higher frequency in comparison with those treated at the lowest and intermediate dose. Here we look at the clonal sequencing of the TR1 cells, which really demonstrates something critical about the T-Allo10 product, and namely that we are delivering functionally selected TR1 cells. On the left panel of the slide, we see the frequency of the 100 top clones that we have identified in isolated TR1, non-TR1, and CD4 positive T cells of the T-Allo10 product. And what you can see that the TR1 fraction contain the clonally expanded repertoire, which are the cells that have already seen the alloantigen, and so they became alloantigen specific. On the right, you have a representative patients in which we see the dynamic of these clones, and you can clearly see that there is an oligoclonal expansion in vivo of the TR1 clones. Some of them expand early, and then some other clones take over later. But really, this oligoclonal signature is the immunological fingerprint of the T-Allo10 product. As our endpoint was to evaluate the speed of CD4 immunoconstitution, here I can show you that a simple linear regression analysis comparing the slope of CD4 recovery revealed a significantly accelerated kinetics in the T-Allo10 recipients in comparison with controls, really indicating that the T-Allo10 cell infusion substantially enhanced the rate of CD4 immunoconstitution, especially in the early phase post-transplant. Although if you look at 6 months post-transplant, really we see a remarkable difference in terms of median numbers of CD4, which are between 300 and 700 for the T-Allo10 recipients in comparison with 100 to 200 for the controls. And if we zoom in the very first 60 days post-transplant, which is our phase 1b efficacy endpoint window, T-Allo10 recipients demonstrated significantly accelerated CD4 recovery, driven mostly by robust expansion of central memory and effector memory that you can see in the right. And although with lower absolute numbers, there is a significantly higher expansion also of naive T cells in the T-Allo10 recipients in comparison with control. Next, we look at the function of the T cells, and here we look really how the cells are able to produce both interferon gamma and IL-2 when stimulated with PHA and CNV and adenovirus peptides. And you can see in solid color the T-Allo10 recipients, and in the shaded box instead the controls. you can notice that both when stimulated with a PHA and with adenovirus peptide, there is a significantly higher response in the TLO10 recipients in comparison with the control. And for the adenovirus specific on the right, when we stratify the combined cytokine response by the activation status of the patients, even if the patients at the time of running the ELISpot had cleared the infection, those patients who had a reactivation had a better response in comparison with the controls. In vitro, we do not see the same significant difference when the cells are stimulated with CMV peptides. However, looking at what really matters, which is the ability of these cells of clearing infection in vivo, here I'm showing you two representative patients who developed a severe infection post-transplant. And so in the left, patient 0308 had a adenovirus infection with over 1 million of copies early post-transplant, resistant to cidofovir. We infuse the TLO10 cells as soon as possible per protocol, and you can clearly see the progressive reduction of the copies of adenovirus while the CD4 expanded, and the patients completely clear the infection around day 16. And overall, it takes about 2 weeks for the cells to expand and being able to clear the infection. And on the right, you see a similar dynamic for a patient who developed, in that case, a significant CMV anemia with over 50,000 copies. Also in this case, the medical treatment was not enough, but the infection clearly cleared very promptly after the infusion and expansion of the TLO10 cells. So far we have seen that these patients, when treated with TLO10, achieved rapid immune reconstitution and clear viral reactivations. However, they also have very low rates of GvHD. And so we looked at the proteomics to understand what is the specific immune signature responsible of this pattern. And so to define this signature, we profiled 384 inflammatory proteins in the plasma of both TLO10 recipient and controls using Olink proteomics. And here you see a weighted gene correlation network analysis that was able to identify 5 co-regulated protein modules reflecting distinct biological pathways reported in the top right. It is pretty striking how the TLO10 recipient treated at therapeutic dose have a significantly downregulated systemic inflammatory pattern, and specifically is the turquoise box of the systemic inflammation markers. And on the right bottom of the panel, you can see that an ordinary least square regression analysis was able to confirm that systemic inflammation IgG values were significantly lower in TLO10 recipients in comparison with the controls, with the T values that were representing over 9 standard deviation from null. So this really gives us an idea that this immune signature, this proteomic signature, is responsible of this unique capability of maintaining antigen pathogen-specific activity without increasing graft-versus-host disease, and at the same time promoting graft-versus-leukemia. So in conclusion, the data that I just showed you report that with the use of TLO10 cells after αβ T-cell depleted graft, we can achieve 0% non-relapse mortality, which is inferior than the 9% we see in the historical control. Patients treated with 3 times to the 5th and 1 times to the 6th per kg, what we call the therapeutic doses, achieve 100% 2 years leukemia-free and GvHD-free relapse survival. TR1 cells infused with the TLO10 cells are detectably quite shortly after the infusion, and they can reach up to 20% of circulating T cells, and then we see them up to 2 years when tracked with clonosequencing. As hypothesized, the infusion of the TLO10 cells dramatically boost the alpha-beta immune reconstitution, and in fact, 75% of the patients achieve 50 CD4 per microliter by day 16, in comparison with 31% of the historical control. In comparison with the historical control, the TLO10 recipient also have a better both in vitro and in vivo response to viral infection. and they have a signature that really is associated with a reduced systemic inflammation, which explain the clinical outcome that I just showed you. So coming back to our first slide, I hope I demonstrated you that really the co-infusion of T allogeneic cells with alpha-beta T-cell depletion graft allow us to address the two other main challenges along with the graft-versus-host disease in transplant for acute leukemia. And in fact, if we look at the all right, I just want to show you that the outcome, as you can see, had improved from 70% to 100%. And that really tells us how we can move the needle when we address each barrier, each obstacle one by one. And with this, I'm just going to thank very much the entire study team, which have worked really hard for producing this data. This is all the team at Stanford, the clinical team, the manufacturing team, and the laboratory team, including the clinical trial program, which made it possible to treat these patients. And thank you for your attention.